Greetings, everyone. Welcome to the 164th session of the online Optom Learning Series, OOLS. And for today's session, we have with us Dr. Gloria Chiu. Dr. Gloria is an associate professor of clinical ophthalmology at the USC Roski Eye Institute, Department of Ophthalmology at the University of Southern California Keck School of Medicine. She received her Doctor of Optometry at the University of California, Berkeley School of Optometry, and also went ahead and completed her residency in cornea and contact lenses at the Southern California College of Optometry, where she's still associated as an adjunct faculty member. Her clinical interests include contact lens fittings, treatments of patients with ocular surface diseases, and irregular corneas. And as per research, her inclination is towards microbial contamination in contact lens related solution, and also obviously the effects of scleral lenses on the ocular surface as well as the optic nerve. She also is a fellow of the American Academy of Optometry and a fellow of the Scleral Lens Education Society. She is a member of the California Optometric Association and very actively been invited by various organizations to give a lecture, share her experience on specialty contact lens management and ocular surface diseases. Very recently, last year in 2021, she was also named as one of the America's best eye doctors by Newsweek. And today, Dr. Chiu is going to take us through her cases, the topic being scleral grand rounds, whereby she'll explain to us how she went ahead in managing some challenging cases of ocular surfaces and irregular cornea. So welcome, ma'am, onto our platform, and let me leave the screen time to you.
Thank you, FB, for that introduction. And thank you so much for the kind invitation to be here at session 164 of OOLS. And this is a real treat to be able to connect with optometrists from all over the world. From what I understand, we have people from India, Malaysia, Vietnam, Nigeria, and elsewhere. So it's just really exciting that technology today can connect us with a click of a button. So without further ado, the title of my topic today is Scleral Lens Grand Rounds, Managing Challenging Ocular Surface and Irregular Cornea Cases. So I was really excited that FB gave me this topic because I think it's just super fun. I've picked some of my favorite cases that we'll be able to explore today. And at the end, we'll take a few questions. So let's get started. Here are my financial disclosures. So we're here to talk today about scleral lenses. Many of you already know these are small, rigid plastic pieces that you fill with liquid and saline and apply onto the surface of your patient's eye. This is what the lenses look like over the cornea. So here you see an eye with corneal transplant. You can see an optic section of the corneal tissue. Above that, the fluid reservoir, and above that, the thickness of the lens itself. And you can see in the picture on the right how far the lens extends over the limbus of the cornea onto the conjunctival tissue. The main indications for scleral lenses include irregular corneas and ocular surface disease. So there's a series of publications by the SCOPE group, and the SCOPE group looked what indication practitioners are fitting scleral lenses for. And it showed that the majority of practitioners are fitting scleral lenses for irregular corneas, and really only less than 20% for ocular surface disease. Here are some photos of patients that I've treated in my clinic successfully with scleral lenses. So we have dry eyes post-chemotherapy with limbal stem cell deficiency, Stevens-Johnson syndrome, which we'll discuss today, Sjogren syndrome, another autoimmune condition, corneas post-transplantation, oftentimes for keratoconus or corneal scarring, as well as ocular graft versus host disease. So let's get to some grand round cases. The first topic we'll discuss is graft versus host disease, or GVHD. This is a complication following allogeneic tissue transplantation, meaning that tissue was taken from a donor. This is associated with a stem cell or bone marrow transplants, where the immune cells see tissue in the recipient as foreign and attack the body. So this can affect various parts of the body, including all layers of the eye. Patients will often complain of grittiness, light sensitivity, have mucus discharge, and even pain in their eyes. Dry eye incidence ranges between 20 to 80% in patients with GVHD, and it can be acute or chronic. These photos really highlight what effects scleral lenses can have on the ocular surface. There's a healing and protective nature of these lenses, and it acts almost like a bandage to improve comfort and vision in patients with dry eye, including GVHD. So the photos on the top show eyes with corneal staining before lens wear, and then 6 hours after scleral lens wear, you can already see healing of the ocular surface. Here's a case example. I have a 65-year-old male with history of mantle cell lymphoma. This is a type of B-cell non-Hodgkin lymphoma, which he was diagnosed with and for which he had a stem cell transplant in 2010. I treated him with scleral lenses 3 years later, and he did very well. His ocular history was significant for artificial tears, lifitegrast, a type of eye medication, IPL, which is intense pulse light, and serum tears. He also has been on various medications, including immunosuppressants, and as well as undergoing a procedure called photopheresis. In terms of his eyes, this patient developed a corneal ulcer 4 years after I fit him into scleral lenses, and we'll talk about that and focus on that in a bit. But before I get to that, I wanted to go over what is autologous serum tears. So these are tears where the patient has their own blood drawn. The serum is extracted from the blood through centrifuge. The concentration can be varied. Typically, compounding pharmacies recommend between 20 to 75%. It can be made at even 100%, but it's not always necessary. Now, these tears must be stored properly. So they must be frozen in tiny little bottles, and the patient will take out one little vial at a time and keep it refrigerated. This is because the serum tears, these components can, over time, be not as effective. So generally, it's recommended only to use the little vial for about 4 to 5 days, and you take a fresh one out of the freezer. These tears can often be helpful for dry eyes, epithelial defects, and recurrent corneal erosion. So in terms of studies in the literature, some actually have said that autologous serum is comparable to artificial tears and that there wasn't much difference. However, others have said that it has led to improved ocular surface objectively as well as subjectively by patients. And this other study published in January of 2021 showed that the serum tears actually improved tear production tests, and you could see it through certain procedures called impression cytology. Here are some visuals of how to produce autologous serum tears, where you draw the blood and dilute them and store them in these tiny vials where you only use one at a time. I also wanted to touch upon this procedure called photopheresis. When I see my GVHD patients, I always ask them about the state of their GVHD because this can affect how their eyes feel. So this process essentially aims to suppress the donor lymphocytes that stimulate GVHD. What they do is they actually take the blood from the body, process it through a separate machine that treats the lymphocytes. These lymphocytes are actually mixed with an agent and it's activated by UV light, and then the lymphocytes and blood are reinfused back into the body. So this process takes a few hours. And I have a lot of patients that do this procedure dozens, if not hundreds of times over the course of several months and years. The overall response rate has been shown to be 50% and higher in patients with skin, oral, eye, GI, and lung involvement. And the best responses were observed in GVHD of the skin, liver, oral mucosa, and the eye. So let's get back to our patient here that we discussed earlier. Here are some photos that were taken in August of 2017 in this patient who developed microbial keratitis, or an infection secondary to the dry eye and microbes on his surface. This led to a desmetocele, which is essentially a very, very thin area on the cornea where the microbes have eaten away at the stromal tissue. And you're essentially left with the endothelium and Descemet's membrane. So these photos were taken about 3 months after the onset of his MK. These photos show the same cornea at 1 year later. So I and my colleagues, we were actually pretty excited about this. We thought, oh my gosh, this cornea has not perforated, which we would typically expect it to. Let's write this up. So we wrote up this case in a journal that was published 2 years ago, in which we shared our experiences in using scleral lenses in a patient with the desmetocele. He's continued to wear the lenses every day, which offered improved comfort and vision and allowed him to maintain functional, activities of daily living. And one of my colleagues, John Gallies, he published his experiences shortly after in a patient with exposure and a neurotrophic cornea where also developed a desmetocele. So he shared his experiences that they also did well in fitting a scleral lens over this very vulnerable tissue. Okay, so you may be wondering, all right, that was in July of 2018. Several years have passed, so let's give you an update on this patient. So this was another year later. This was in December of 2019. As you can see, the area of the desmetocele has enlarged. It's no longer a small oval. It's actually almost the size of the pupil. On the photo on the right, you can really see how large that area is and how thin the cornea is. You can also see a profile of the scleral lens on top of the cornea. Another year later, this area of desmetocele has enlarged further. However, he has not perforated. And again, another year later, it looks about stable. So we finally achieved some stability where we're no longer seeing melting of the corneal tissue. And just so you don't think I'm neglecting his other eye, this is his left eye. He's continuing to wear scleral lenses with good comfort and vision. So some clinical pearls from this case. In terms of co-management, it's very important that you can work with ophthalmologists and hematologists in your GVHD patients. When this patient had active epithelial defects, we would prescribe topical antibiotics. Another drug that has been out in the market now for a couple years is called Oxervate and has been used to treat neurotrophic corneas, especially those with epithelial defects. So that's something that you could consider to prescribe if it's available in your country. In this case, we didn't use it for this patient. And in terms of timing for a corneal transplant, my corneal surgeon has been very hesitant to move forward with surgery. Because this patient's cornea was continuing to melt, he was worried that the transplant itself would not stabilize and that it would fail. This patient also went to see another ophthalmologist who had a slightly different view and said, sure, I'll operate on you. So even working with different doctors, they may have different views on what is the right therapy. And as this cornea was changing, we did initiate oral therapy for this progressive corneal ulceration, which included oral prednisone at a pretty high dose, which is 60 milligrams per day, as well as tacrolimus and another one called Jakafi. So when I see GVHD patients, I always want to know, are they on any immunosuppressants? I know the medications vary all over the world, but there are 5 in the United States that I like to ask about, including oral prednisone, which is probably the most common, tacrolimus, Jakafi, sirolimus, and the newest one called Resurrock. In this patient, scleral lenses were used consistently. He actually was never taken out of them. And I even asked my surgeon, should we discontinue wear and possibly try an amniotic membrane graft or another therapy? And he really said no, and he thought the scleral lenses would be the best for the patient in terms of overall protection. One thing I did have to do was educate my patient profusely on the risks of corneal perforation. This is one of the very few patients who actually has my cell phone number and is aware if anything happens to let me know right away. So some questions I've been asked are, how thin of a cornea can you fit safely in a scleral lens? Well, this case demonstrates that you can fit a cornea that's pretty thin as long as the patient is careful and you monitor closely. And overall, you need to really consider the pros and cons. Is lens wear helping the patient, or is it hurting the patient? In this case, it helped him in many, many ways: comfort and vision and protection of the eye. So here's our second case of a GVHD patient, 45-year-old female who I've been seeing for about 5 years now, history of AML and also a stem cell transplant. Presented with severe dry eyes, painful knife sensations, and light sensitivity. She had been on several medications in the past with little relief. When she presented, she had diffuse 4+ staining in both eyes. And shortly after I saw her, she started a new immunosuppressant drug in which she developed more eye pain and problems. So remember that sometimes their symptoms can vary depending on the medications that they're on. So essentially, we started scleral lens treatment for her soon after I saw her because she developed bilateral epithelial defects. I was able to order lenses and have them FedEx the next day. Prophylactically, I did put her on some topical antibiotics. This is what the patient's eyes looked like on the second day I saw her. And when you put sodium fluorescein on the surface of the cornea, it really highlights the area where the epithelium has been compromised. You can also see some corneal staining and the really diminished tear film. So on the second day, patient came back. We trained her on proper application and removal, cleaning and care, because you know how important that is, especially in compromised corneas. And this patient actually lived in a different state. So it wasn't easy for me to follow up with her every day. She actually went home. I told her to wear the lenses on a daily basis and continue the topical antibiotic. So this is November 3rd. She came back 5 days later, still using the topical steroid as well as a the topical antibiotic as well as a very low dose topical steroid. And you can see that the epithelial defect has improved a little bit, but not fully, and there's still a very dry surface. Now, a couple weeks later, she finally came back because she lived in a different state. And by this time, even with just daily wear, not overnight wear, her epithelial defects had resolved in both eyes. We stopped the antibiotics and started a topical steroid to help with the inflammation and a bit of the corneal haze. So I just wanted to mention this because scleral lenses have been shown in the literature and many studies to be very effective in helping with the healing of persistent epithelial defects when it's been intolerant to other mechanisms such as a soft bandage lens, topical lubrication, or even amniotic membranes. So it's something to consider for those very diseased eyes that are not healing as long as you follow up closely. There's also a method that's been written up in the literature about extended wear, where patients actually wear the lenses overnight for optimum coverage and protection. If you're doing this, it's important that the patient still take the lenses off multiple times a day to clean the fluid, clean the lens, and rinse out their eyes and get in medications as needed. Let's move on to another condition called Stevens-Johnson syndrome. So this is a form of toxic epidermal necrolysis where cell death causes essentially the epidermis to separate from the dermis. And you can see these photos of a real patient where their skin is sloughing off. This typically happens as a reaction to medication, and it starts with fever and flu-like symptoms, and the patient ends up in the burn unit. This definitely can affect the ocular surface. So here are photos of some eyes post Stevens-Johnson syndrome. Some patients, I would say more in the past, have a procedure where they have mucous membrane grafting, where they take tissue from another part of your body, oftentimes the inner part of your lip or your mouth, and line it on the lower or upper eyelids because it's so rough and scarred. I don't see this procedure done as much now that we have scleral lenses. In terms of complications to the ocular surface, a lot of SJS patients also develop trichiasis or dystichiasis, where eyelashes grow and are misdirected towards the cornea and cause a lot of scratching and foreign body sensation. So scleral lenses in SJS are really helpful in terms of protecting the cornea and giving comfort to the patient. So here you can see these photos enlarged a little bit more, where you actually see eyelashes growing out of the meibomian glands, and this is not a normal presentation, and these patients have to come back every couple of weeks to have these lashes epilated. So let's talk about a case. This is a 38-year-old Indian male who developed SJS from acetaminophen about 10 years ago in 2012. So this was the patient in July of 2018. He was fit with scleral lenses out of state and then moved to Los Angeles, where I took over his care. So I want you to focus here on these photos. The photo of the cornea that's relatively clear is the right eye, but you can see some of the scar tissue or symblepharon temporally. In the left eye, you can see this very active, aggressive neovascularization really just spreading over the superior half of the cornea. This is very active neo in July of 2018. Now, a year later, the right eye is looking pretty stable, and now you can see what's happened with this conjunctival tissue and the neovascularization. Well, the blood vessels have kind of calmed down a bit, but now we're seeing what is called keratinization over the outside of the conjunctiva, where it becomes waxy and shiny, and conjunctivalization over the cornea. And this is actually a protective mechanism of the eye to shield the delicate cornea, but it has adverse effects. Obviously, it can cause decreased vision and a lot of irritation because of the scarring and symblepharon. Another year later, well, the left eye you can see is relatively similar in terms of this conjunctivalization, and now the right eye is starting to be affected. Now you can see some of this white opacification on the lower part of the right cornea. So we're watching this patient very carefully. We're seeing him very often, and unfortunately, in January of 2021, he developed a scratch which led to an epithelial defect in his right eye. It took a couple months for it to fully heal, and during this time, he met every single one of my corneal ophthalmologists on the service, and he came in a lot. We tried all different kinds of therapies to treat this right eye, including antibiotics, steroids, ointments, and it just took time for this inflammation to subside. So this is a couple months later. Thankfully, the epithelial defect has resolved, but unfortunately, you're seeing this really shiny, waxy development over the inferior cornea, and this is called keratinization, and you're also seeing this conjunctivalization. So although the cornea did not perforate, you're seeing a lot of scarring where the active defect was. Thankfully, this patient is still able to wear scleral lenses in both eyes and achieves about 20/50 vision in the right and 20/30 in the left. But you can see really how much his eyes have changed over the course of just a couple years, going from almost a clear cornea in the right eye to this presentation that you see now on the left side. So in terms of how we treated this patient with SJS, when we talk about throwing everything, throwing the kitchen sink at someone, this is essentially what we did for this patient. He tried all the drops, topical medications, serum tears, ointment, steroids, and ended up on medications including tacrolimus ointment and very high concentration of cyclosporin drops to control the inflammation. And during this entire time, scleral lenses remained very important. So some clinical considerations, we have to remember that SJS patients have challenges with mucus, midday fogging, eyelash growth, the symblepharon, which leads to challenges with the scleral lens wear because it pulls the lens, conjunctivalization and keratinization. And when you put a patient on steroids, make sure to check their eye pressure. This patient actually had a steroid response where we had to discontinue steroids. Obviously, he developed an epithelial defect where we had to monitor. And some recommendations for your SJS patients: you need to anticipate challenges, see them frequently, and educate them on expectations. Let them know that their scleral lenses fit might have to change when their eye surface change. And I've also referred this patient to a vision rehabilitation provider already. He's in his 30s. I'm worried that if the scarring progresses, he might lose further vision. And if he can see a low vision or vision rehab specialist sooner and become familiarized with what technology and resources are available, he'll be more prepared in the event his vision declines. So in terms of surgery, these patients with severe ocular surface disease still need cataract surgery. So here's a 48-year-old male who I treated with scleral lenses 10 years ago in 2012. Overall, he's been doing very well. But he finally developed cataract. So in May of 2020, in his left eye, he had cataract surgery. Unfortunately, he developed an epithelial defect 2 weeks after the surgery. It did resolve, however, it left him with a scar and some inflammation. So same thing with his right eye. Almost exactly a year later, he again developed an epi defect after his surgery, which again resolved after a couple months. So I bring this case up because you should be very aware of potential complications in your dry eye patients after surgery. Their risk is higher of scratches, abrasions, and infections. And this patient now, just a couple months ago, he's seen 20/30 and 20/20 now, having had cataract surgery and still wearing scleral lenses, which did need to be updated in the power after the surgery. Typically, I wait a couple weeks before resuming scleral lens wear. However, so these are some photos of that patient, which she kindly allowed me to share. This is what SJS can do in the acute stage when he was in the burn unit. The photo on the right shows chronic complications, including affecting the skin and the eyes. So what I wanted to say is during the post-operative healing post-operative healing period in patients like this, you may consider resuming scleral lens wear sooner than a month, because that may actually prevent the breakdown of the epithelium. So this is what the patient's eyes looked like after surgery. So you can see in both eyes that there's this corneal scarring, and that's where the epithelial defect developed. Now he's comfortable back in his scleral lenses, thankfully. So let's move on to an entirely different condition called keratoconus. This is a corneal disorder with central thinning and steepening. It's often bilateral but asymmetric. It's progressive and non-inflammatory. So you can see some photos here on the right where you see on the top asymmetry, definitely more scarring in one eye compared to the other. And in the brown eyes, you can see pretty moderate central scarring in both eyes. So it's pretty symmetric. The onset of keratoconus is typically in the teens at the time of puberty, so around 13 to 18, and the prevalence and incidence varies with geography, ethnicity, and the study that you're looking at. And typically the prevalence ranges from about 1 to 4% depending on the study, and the incidence, which refers to the number of individuals who develop a condition during a specific time period. The incidence of this disease has actually increased in the last decade or so, and I think that is due to better detection and better tools for optometrists to detect keratoconus earlier and report it and get treatment for these patients. In terms of etiology, there's definitely a genetic component as well as an environmental component, including UV exposure, atopic conditions, which include eczema, asthma, and allergic conjunctivitis, and as well as potentially irritation from contact lens wear. So if your keratoconus patients are suffering from allergic conjunctivitis, definitely treat them. Don't forget to flip the eyelid and look underneath for abnormal papillae, which could be leading to itching and the rubbing. So there are many topical anti-allergy drops available, cold compresses, artificial tears to help with this, as well as oral allergy medications. And in terms of contact lenses, many patients do well with RGPs, but if that's exacerbating the irritation, you could consider switching to a scleral lens. Risk factors include family history, eye rubbing, and age, which we'll talk about in a study in a little bit. I also want to bring up that we now have genetic testing for keratoconus. This has only come out within about the last year where it's been readily available. I just got my hands on these tests in my clinic a couple weeks ago, and you essentially take a mouth swab, send it to the lab, they analyze it for any genes associated with keratoconus, and the patient gets an objective result showing their risk for keratoconus. So this may help the patient in terms of planning for their future, making sure they get their eyes treated, and potentially considering early cross-linking to prevent progression. So how do you make the diagnosis of keratoconus? Well, you can use your retinoscope. You will often see a scissoring effect instead of a clean with or against motion. When you're refracting a patient, if you can't refract them to a crisp 20/20 and you wouldn't otherwise expect them, to have decreased vision, consider a corneal disorder, looking at their eyes in a slit lamp. So signs that you'll often see in keratoconus include central thinning, ectasia, steepening, a ring called Fleischer's ring, where you have iron deposits at the base of the cone, and these vertical stretch marks called Vokes striae. Now, typically, we want to detect keratoconus earlier than when we've seen these signs. That means they've progressed, and we are lucky now to have corneal cross-linking, which has been demonstrated now over about 2 decades globally, that it's been effective in slowing or halting the progression of keratoconus. We also have advanced mapping with topographers and tomographers to really look at the elevation maps in the front and back of the cornea. So sometimes even the posterior elevation map can detect keratoconus earlier than anterior surface findings. So here's a case, a 15-year-old male who came to see me. So he and his mom came to me very distressed. This young boy, smart young boy, but he was having behavioral issues, trouble with his baseball because he's an athlete. Well, it makes sense. His incoming vision is 2300 and 2100. He has high Ks in the 50s and 60s in his corneas, and glasses did not work for him. It just was unable to give him functional vision. He already presented with central striae and mild scars. So what did I do? Well, I sent him immediately for cross-linking. So I want to point out a few things. If some of you don't have tomographers or topographer, an autorefractor can still be very helpful in the diagnosis and monitoring of keratoconus. As you can see on this photo on the right, the clue is that the autorefractor will give you very abnormal and strange readings in irregular corneas. Minus 25, plus 13. The right eye, it didn't even give us any readings. However, in terms of the Ks, it's generally decent and can give you an idea of whether you have a steep cornea. So a couple clues in terms of detection of keratoconus. You want to look out for asymmetry in the eye itself. So you're seeing in the left eye here, Ks of 61 and 53. Well, that's a big difference between the Ks on the surface of the cornea. That's a clue that something's wrong. And also look at asymmetry between the eye. If one eye's Ks are much higher than the other. And then also looking at the age of the patient. So for this patient, I was definitely not going to forget his vision correction, but wanted to get him to my corneal specialist for cross-linking immediately, because studies have shown that some important things to consider in referring for cross-linking include younger patients and those with the K max, which is the steepest part of the cornea, of greater than 55. This study that was published in July of 2019, National keratoconus natural progression, a systematic review and meta-analysis of over 11,000 eyes, concluded that we should follow up closer in patients younger than 17 and those with the steeper Kmax than 55. I would argue that even if you're seeing Ks of 48 and 49, that should be a red flag that they may have a corneal ectasia. Another study published last year showed that delayed cross-linking for just 3 months during the COVID pandemic actually led to progression and worsening of vision in patients. They looked at 46 eyes. So again, we don't want to delay cross-linking, particularly in young patients. So these were the tomography images. You can see a lot of steepening and thinning already present in both eyes. And here you have scleral lenses on the patient's eye. So concurrently with referring him for cross-linking, I ordered his contacts, fit him, and he improved to 20/20 in each eye. He and his mom were so happy, and now this patient can see. He's also finally been cross-linked in both eyes within the last, he got it after a couple months due to just insurance, prior authorizations, and now, we can feel a little bit more relieved that we treated his corneas to the best of our ability, and he's seeing better. And the reason why we want to treat our patients soon is to avoid complications in advanced keratoconus, including corneal scarring, thinning, as well as corneal eye drops. So here's a young patient in her 20s, and you can see this significant dense scarring in her right eye. This is what happened after corneal eye drops. Essentially, you have a break in the inner layers of the cornea where the aqueous fluid rushes into the cornea, which leads to thickening and edema. And this haziness is very disruptive, and the patient can't see oftentimes for weeks until this edema subsides. So we don't want this to happen, and it typically happens in the most advanced keratoconic cases. So I also want to bring this study up, which is pretty interesting. It came out last year, that looked at the influence of scleral lenses on the corneal curvature of keratoconic eyes. And they looked at the flat K, steep K, and Kmax using corneal tomography before lens insertion, after 6 hours, and the next morning. And they essentially found that corneal flattening was observed for all 3 parameters immediately after removal, but it wasn't statistically significant. So this is just something to keep in mind when your scleral lens patients take off their lenses and say, gosh, my vision seems a little off for a couple hours. It's because it's been demonstrated in studies that the cornea flattens a little bit with scleral lens wear. So essentially, there is minimal transient alteration in anterior corneal curvature, and corneal thickness actually increased after 6 hours of lens wear. So just something to keep in mind. So here's another case that I'm excited to share. I've not shared this anywhere else before, so you guys are the first, guys and girls, are the first to hear it. This is a longtime patient of mine that I think was one of the first patients I started seeing when I started at USC. I started there in 2009, and maybe I started seeing him in 2010. So this 97-year-old male presented with advanced keratoconus, which developed as a young adult. He wore every single type of contact lens available at that time, which included RGPs and even fenestrated scleral lenses, which had very low oxygen permeability. I can only guess that they might have been made out of PMMA, which is a plastic with a 0 oxygen permeability, because they were fenestrated. So eventually he was fit into scleral lenses in the 2000s. And when he came to see me, I refit him in 2010. He had very, very thin corneas as measured by pachymetry of less than 100 in both eyes. For many years, we debated, should you have a transplant? Should you not have a transplant? He was already in his 80s by the time I was seeing him. Ultimately, we decided to proceed with a penetrating keratoplasty in his left eye. So what happened? Well, now it's 2022, and he's still wearing scleral lenses in both eyes. He's actually doing fine in both eyes. The one that was not transplanted and the eye that was transplanted. His vision in the transplanted eye, though, is a little bit better and does tend to fluctuate a little bit in both eyes. But I wanted to share these photos. This patient gifted me with these scleral lenses that he received in the 60s. So this was obviously before I was born. And these scleral lenses, he said he had designed by an optometrist in the 60s, but he couldn't wear them for more than an hour because his vision would get blurry. So this leads me to believe that they had a low oxygen permeability. So it's exciting how far we've come in the last few decades with improvements in scleral lens designs, materials, including increased oxygen permeability, and how to fit complex corneas. So this is what this patient's eyes looked like in April of 2010. You actually don't see a lot of corneal scarring. They were just very, very thin. And here, a year later, you see he's wearing scleral lenses in both eyes, but you see the incision marks from the corneal transplant, as well as a few interrupted sutures in his left eye. Now, interestingly, this patient was actually able to wear his same scleral lens with very little change in the prescription, which is unusual. And these are photos that show the profile of his cornea. So on the right side, you see how thin this cornea really is centrally. And with the left eye, obviously it's more even throughout because he's had a cornea transplant. And I just saw this patient a couple weeks ago. We took photos again. He's doing stable, still super, super thin cornea with excessive ectasia in the right eye, but he's okay. And here you see his left eye with the transplant, but it's clear. And I just ordered him new lenses and he is doing well. So a couple of pearls here on keratoconus and management with scleral lenses. Well, scleral lenses are a great option for keratoconus correction. Make sure to remove the lenses on examination because good vision and comfort could actually be masking progression, particularly in younger patients. Don't forget to refract them and follow their Ks with keratometry or topography or tomography. Remember to follow closely in young patients and high-risk patients, so those with family history or eye rubbing or asthma or allergic conjunctivitis. And remember that we now have corneal cross-linking available, which aims to halt and slow progression of the disease. We have many surgical procedures actually now to improve vision, and I don't have time to talk about them today, but includes corneal intacts and several other procedures, topography-guided PRK. And I do work in the ophthalmology department, so I work very closely with my surgeons. They refer patients to me for vision correction, and I refer to them for surgery or cross-linking as needed. I wanted to touch upon this publication, which is an overview of the 2021 keratoconus testing consensus statement, which was published in Modern Optometry and Cataract and Refractive Surgery Today, where a group of 13 ophthalmologists and optometrists gathered to really discuss their best practices and guidelines for understanding the incidence and impact of keratoconus and looking at, how to identify and address these patients. So you can access this free at this website listed here on evolvemed.com. And I was very fortunate to be on this panel to discuss, management of keratoconus. So something that you can look at in your own free time. In summary, scleral lenses are a great treatment option for both irregular corneas and ocular surface disease. Scleral lenses typically are not the first line treatment though. You often will consider other therapies or lens options first, including soft, custom soft, toric, RGPs, hybrid lenses, because scleral lenses do require more involved daily care and compliance. Obviously, you need to have plungers and tools and the right saline solutions to fill that lens before you apply it to the eye. But scleral lenses, as I've had the privilege of seeing over the last 15 years or so, are certainly life-changing and have helped a lot of patients when other therapies have not been successful. So I wanted to thank you all for your attention and for joining me from wherever you are. Please feel free to reach out. It's really been a privilege and a pleasure to be with you here today and share these cases. I hope you enjoyed them. I hope it was fun. And I will hand it over back to FB to close and to address some questions if we have any.
Great. Okay. So thank you so much, ma'am, for that wonderful, presentation and taking us through some really interesting cases, I would say, and the follow-ups and how did you go about at each step. I think that's really helpful as talking about as a clinician most of the time, you want to see how it goes on and what changes you made at each step, what advices you gave to your patient. And at the end, you summed up everything, and it's really helpful for us. So thank you so much for, taking us through your journey of these cases.
Of course. Thank you for having me.
I see somebody has joined from Nigeria and it's 4 a.m. there. Thank you so much.
Oh my gosh. That's so nice of you. You should be sleeping, but thank you for joining. That's so great.
That's great. So thank you so much, everyone. And okay, so one question which came in, I'm just going to put that question straight ahead, and which asks about your advice on, sleeping with scleral lenses, or in other words, do you prescribe in any conditions extended or continuous scleral lens wear? What's your take on this?
Great question. There are only very few instances in which I would prescribe overnight or extended wear, and that's typically when they have active, persistent epithelial defects. And when you have patients sleep in their lens, I alluded to this procedure in my patient with GVHD. So I've had some patients that have these defects that just will not heal even with drops, bandaged soft lenses, which they sleep in. And I put them on a regimen of sleeping in their lens overnight. I do recommend putting 1 drop of a non-preserved topical antibiotic within the chamber of the lens as a prophylactic measure to prevent infection. And when these patients sleep in their lens, it doesn't mean they leave them in for, 100 hours at a time, days straight. They still have to take them out at least, I would say, every 8 hours to clean it, rinse it, put their medications in, clean the lens, remove any microbes or bacteria multiple times a day. I try to get them back into daily wear as soon as possible when the ocular surface is showing improvement, because risks have been shown, to be higher with overnight wear. A lot of studies have shown infection, with orthokeratology or sleeping in soft lenses. So sleeping with scleral lenses is not ideal, but when you're using it as a therapy to treat epithelial defects, it sometimes can be utilized, but oftentimes you need to follow up with the patient every few days. But otherwise, I don't advise it.
Great. Okay. So I think that's really well summed up. And I think in the first or the second case, you did mention that your patient came up every 5 days and then 3 days, 7 days later, so that you monitor them for everything before they, continue wearing it for continuous. So that's a very good takeaway message as clinicians and optometrists, that do follow up with your patients. Don't just think that everything is going to be fine, right?
Right.
Okay, another question, which is what is your advice on fitting scleral lenses post corneal cross-linking? How many days or months or years do you wait before you fit them with sclerals?
Excellent question. So as you know, cross-linking is indicated for patients with progressive keratoconus, and these patients often can't function well in glasses. So you don't want them to miss work and school and be unable to drive for too long of a time period. So what I generally recommend is in patients who have been trained already with application and removal with scleral lenses, they can sometimes get back into contacts sooner after cross-linking, as long as the epithelium has healed. So there's epi-on cross-linking and epi-off, and epi-off is currently the only FDA-approved protocol in the United States, and it's shown to be more effective typically than epi-on. So most of my patients undergo this process. So the first week, they have a bandage contact lens on. And then when they go back for their post-op visit, when you remove the bandage lens, if the epithelium has healed and you're off your topical medications, you may consider putting them back into their contacts. So for scleral lenses, the earliest I would consider is probably 2 to 3 weeks, typically 1 month, if they're already proficient in application and removal. If they're not and they're training after the surgery, you might want to wait a little longer because you don't want to hit the sensitive epithelium that's just healed. Now, in situations where patients are wearing contacts that sit on the cornea, like RGP contacts, hybrid contacts, you might want to wait a little bit longer, maybe a month and a half, 2 months, to give the epithelium a little bit more time to heal sufficiently. But definitely, you don't need to wait 6 months. You don't need to wait 3 months. I would think as long as the epithelium is healed and they're looking pretty stable when you're doing corneal measurements, you can get them back into contacts, but you just want to make sure that the surface has healed. And oftentimes, I might even try to train the patient in scleral lens application and removal before their surgery. So after, they're not going to risk hitting their eye and damaging the epithelium because it just healed. So that's my answer for this.
Great. Okay, thank you so much. And one more question, which is about topography, and when it comes to scleral lens patients, how frequently do you need to do the topography? I'm just reframing this in a way that how frequently do you do a topography if you have a scleral contact lens wearers to look at their progression or
understood. So in younger patients, definitely more frequently. So if your patient is between 10 to 25, I might be doing topography even every 6 months. If they have high risk, meaning family history, they have allergies, eczema, atopic conditions, I might be doing topography every 3 months. And if I see progression, would send them for cross-linking immediately. In patients who are in their 30s and 40s and above, and they're wearing scleral lenses, I still have them remove it every time in order to check for vision, eye pressure. You always have to take the lenses off to look fully at their corneal health and eye health, but you may not need to do topography as often in patients who are older. So at that point, maybe annually. But if they're young and they haven't had cross-linking, or you might be suspecting progression, potentially every 3 to 6 months.
Okay, and do you want them to be off their scleral lenses for a certain period of time before you do the topography? Do they come into your practice off lenses for 24 hours and you want to do a topography, something like that?
So that's a good question, and that's why I brought up the study. So that study, and there's a few studies in the literature that show a slight flattening effect by a small amount, typically less than a diopter, with short-term scleral lens wear. So I don't recommend my patients come in without their lenses because it's really disruptive to their life. And sometimes they can't get a ride and they have to drive with their lenses, right? So I just, as long as I'm measuring them consistently after lens removal, then that flattening effect is probably consistent. So we're looking for change over time. So just be aware that there might be a small flattening effect, typically less than a diopter. And in the study that I shared earlier, it was not even statistically significant. So you can just have them remove the lens in office and then conduct topography.
Okay, great. And another question which popped up is any difference in your line of treatment when it comes to ocular dendritic? Probably I'm looking at dendritic ulcer kind of a thing, herpes related or something like that. Do you do something different?
So in terms of herpetic disease, I actually just saw a fresh dendrite in a patient that was referred to me for scleral lenses. So at this time, I did put on a lens very, very quickly just to assess best corrected vision, because that was what she was sent for, but immediately took it off, disinfected the lens, and she was put back on treatment for herpes. So she was put back on oral acyclovir, and I sent her back to her ophthalmologist who had managed her herpetic disease previously. So you don't want to be fitting eyes with any contact lens when they have an active ocular dendrite from herpes. You want to treat it with oral therapy and have it stabilized before you fit them with contacts.
Great. Okay. A couple of more questions, and I think this one is a bit interesting when it comes to, thin corneas, as your patient had about 100 microns and things like that. Any special tips or considerations you would suggest to us when we are fitting these kind of thin corneas with scleral lenses?
So I've been able to fit scleral lenses in all shapes and sizes of corneas. And at this point, nothing really scares me. But it's important to educate your patient on proper cleaning, care, and hygiene of their scleral lenses, their supplies, their tools, their cases, because in severely diseased eyes, they're at higher risk for infections, complications, and such. You also want to make sure when you train them that you've monitored their technique and do not release any lenses before they're proficient with handling. So make sure they know how to put them on, take them off accurately before you send them home with them. And I find that these patients do very well. So just make sure you've educated them on handling, cleaning care, and that you also follow up with them closely. So many of these patients I see, if not, every 3 months, at least every 6 months.
Okay, great. And one connecting question which just came up because there is a thin cornea, I think it's about endothelial cell density. And what's your take on, performing specular microscopy on patients with thin corneas or who have advanced keratoconus in high drops in relation to scleral lens fitting? Do you normally do that for all patients, or it is just for some category of patients?
I do not perform endothelial cell count on every patient routinely. I would if I could. The instrument is just not easily accessible. I think we have one for research, but it's very difficult to use, and I don't even know where the equipment is at this point. But I think it would be most important in patients who have had corneal transplants, because with scleral lens, where you're creating a hypoxic situation over their cornea, so if you don't have access to measuring endocell count, what you can do is look at corneal thickness. So I often measure pachymetry, which is much easier. I have a handheld tool. It's much less expensive to have in your office. Or if you have corneal tomographer, it does give you global pachymetry measurements so that you can look at corneal thickness over time. And if you're seeing thickening, you might need to discontinue lens wear, increase the oxygen, switch to an RGP, or whatnot. But I do not measure endocell count routinely.
Great. Okay. So one last question before we wrap up, and this is again popped up a lot of times and people are really wanting to know your opinion, is the use of artificial tears or topical eye drops, any kind of eye drops over the scleral lenses. So do you advise them? What are the tips and tricks we must keep in mind if we are doing so?
Very important question. So with the scleral lens, you don't have proper penetration of the drug to the ocular surface. So it's important that patients take their lenses off before using any topical medication, meaning antibiotic, steroid, glaucoma medication, whatever it is, dry eye medication. You have to use it when the lens is off the eye and wait at least 15 minutes before application of the lens again. Now, you can use non-preserved artificial tears as often as needed on top of the lens because it just lubricates the surface and minimizes friction with the blinking of the eyelid, but no medicine on top of the lens.
Okay, great. And this really has popped up in a couple of our sessions as well, because our mode of treatment for patients complaining of dry eye, I feel lenses are getting dried off earlier. So first thing what we tend to do is prescribe some preservative-free artificial tears. So yes, it might, as you said, might give some comfort, but then if it's antibiotic or we are looking for any treatment measures in terms of prescribing drug, it's really important to understand that they need to remove, because the penetration is not that great, right?
Correct.
Yeah, so it all depends on what type of topical eye drops are going to be prescribed and for what condition. That's the whole idea of this particular question. Yeah.
Right.
Awesome. Great. So I think with that, we have covered most of the questions, and thank you so very much once again, for taking out time and doing the session for us and sharing all your expertise.
Thank you so much for having me. It's really been a pleasure, and I'm just very impressed that we have people attending from all over the world, and thank you for being up at very odd hours of the day. It's currently 8 p.m. for me in Los Angeles, California, and so I am just gonna have some dessert probably. But thank you again. OOLS is amazing, and I'm so glad that I connected with you. Thanks again, FB, for this really special opportunity, and thank you to all of you for being here today.
Most welcome, most welcome. So we do have a session planned on next weekend. It is on a Friday. It's not over the weekend. It's on a Friday. Maybe Friday is a weekend for some of you, but it's on Friday. And see you all next week again. Until then, take care and be safe. Bye-bye.
Bye, everyone.
Bye. Take care, ma'am. Bye.